Recent advances in the knowledge of progressive metastatic colorectal cancer have led to many more options than we had before. But this has also increased the complexity of decision-making and opened the need for a better understanding of what we can do as physicians to better inform our patients. For us all, as physicians, it's extremely important to collaboratively work with our patients to make the proper treatment decisions. In this educational program, we specifically focus on third-line treatment decision-making with the goal of obtaining a patient-informed consent and commitment toward the treatment decision.
Collaborative decision planning can help craft an individual option for your patients, thus increasing the chance of success. I'm going to summarize the 5 steps now. The first step, disease progression and why third-line treatment is required. Step 2, the recommended treatment and why it differs from first-line and second-line treatments. Step 3, the different third-line treatment options available and the relative advantages and disadvantages of the same. Step 4, awareness of the safety and side effect profiles of these treatments and how to best manage them. And finally, a reminder of the treatment goal and what success would look like.
By interacting and working collaboratively with our patients, we can really achieve the best results. A role-play case study will bring into life this 5-step communication framework.
I want to introduce a theoretical patient case study. It's a rather young female rectal cancer patient, 50-year-old Sandra McKenzie. She was diagnosed with rectal cancer several months before. Primary tumor was resected. She received an adjuvant treatment. However, 16 months later, she was suffering from a relapse of the disease by hepatic lesions. She received standard first and second line chemotherapy plus antibody, and now the disease progressed. The patient is in a special situation. She's a young patient and she has a daughter who is in college at her last year. The patient wants to attend the graduation ceremony in 3 months from now on.
Come in.
Morning, Dr. Ross.
Oh, good morning, Sandra. How are you today?
Not too bad, considering.
Well, that's good. And how are you feeling symptom-wise?
I'm doing really well, actually. Although my biggest complaint is being very tired all the time. And I'm also getting some funny numbness and tingling in my hands and feet.
Okay. These are not surprising, really. How well are you able to deal with daily activities?
Mostly okay, as long as I have time to rest and I go to bed early. The thing I'm worried about, though, is how I'll manage my daughter's graduation. It's such an important time for us.
Okay, well, we'll keep that in mind. And when is that?
It's in 3 months, in June.
Okay. Well, we'll talk about our options. You've done well persevering on your second-line treatment, and I'm glad you're feeling better than last time we met. We're here to review where we've got to after around 18 months treatment. You've been on second-line treatment now for about 7 months, haven't you? Now, I've got your latest scan results, and I'm sorry to say that there is evidence that the disease is now progressing, with some signs of it in your liver. This is, I'm afraid, not altogether unexpected and a sign that we have reached the limits of what the second-line treatment can do. So, for this reason, I think we need to look at another, what we call third-line treatment, to try to gain control of the disease. Do you have any questions about this?
No, I can't really think right now.
Are you okay if we continue with this discussion?
All I want to do is be able to be at my daughter's graduation.
I understand. And we can focus on that. I realise that this is very difficult for you. We need to look at the next phase of treatment, what, as I said, we call third-line treatment. and this is different to the treatments you've had up to now. Our goal with third-line treatment is to try to stabilise the disease and give you the best quality of life possible. There are different third-line options available, and a couple I can suggest may be best for you based on your treatment history and current disease status. Would you like me to explain more about the suggested treatments?
Okay. Can you first give me an idea of how long I would have if I didn't consider any third-line treatment?
It's very hard to say, as every patient is different. Without treatment, the disease is likely to progress. But with treatment, there's a good chance we can get back control of the disease. I do think that you are a good candidate for third-line treatment, if you are willing to consider it.
Right. I really need to be at my daughter's graduation, so I'll give anything a try.
Absolutely. The third-line treatment options work in different ways. You are generally fit and well, and that means we can choose which treatment is right for you. It's important to remember that the goal here is to improve your prognosis. We balance the benefits of the treatment against its potential side effects. This is what we call the benefit-risk profile. All treatments have different benefit-risk profiles, and so we need to consider what your preferences and expectations are of the treatment so we can make the right decision. Does that make sense?
Yes, I think so.
Our patient is now in a difficult situation. First and second line treatment failed, and the morale is rather low in this patient. We have now, on the one hand, to inform the patient about the status of the disease, and on the other hand, we might consider that the low morale might affect decision making of the patient. You have to make sure that you understand the patient wishes and also the role of the accompanying person next to the patient. You have to take a rather simple language to transport your information, so avoid jargons. Allow patient to take the time the patient needs to take on board all this information. Address the low morale of the patient, relieve any barrier which would prevent the patient to express their feeling, their fears, and also if the patient have questions, allow the patient to ask all the questions at this time. Cure at this stage of the disease is very unlikely. You have to make sure that the patient understands when you continue treatment, what is the aim of continuing of care.
Come in.
Morning, Dr. Ross.
Good morning, Sandra. How are you?
Not too bad considering.
How are your symptoms?
I'm doing really well, actually, although my biggest complaint has been very tired all the time, and I'm also getting some funny numbness and tingling in my hands and feet.
Okay, so we're here to review where we've got to after around 18 months treatment. You've been on second-line treatment now for about 7 months, haven't you? Now, I've got your latest results from your scans, and I'm sorry to say that there is evidence that the disease is now progressing, with some signs of the disease in your liver. This is, I'm afraid, not altogether unexpected, and a sign that we have reached the limits of what the second-line treatment you have taken can do. For this reason, I think we need to look at another, what we call third-line treatment, to try to gain control of the disease. Are you okay?
Yes. All I want to do is be able to be at my daughter's graduation.
Okay, well, we'll look at what we can do as we can move on to the next treatment phase, what we call third-line treatment, which is different to the treatments you've had up to now. There are different third-line options available, and there's a couple I can suggest that may be good options for you based on your treatment history and current disease status. You're generally fit and well, and that means we are in a good position to choose which treatment is right for you. All treatments will aim to improve your prognosis. We balance their benefits against potential side effects, and this is what we call the benefit-risk profile. All treatments have different benefit-risk profiles, and so we'll consider this when we make the decision.
And what if I don't go on to third-line treatment?
It's very hard to say for sure. I mean, people respond differently, but you'll have a better prognosis generally by moving on to further treatment.
Oh, okay.
Let's now have a look what options are available after failure of first and second line treatment in metastatic colorectal cancer. On the one hand, we have an tyrosine kinase inhibitor, which is regorafenib. This has been approved in clinical phase 3 trials and has a level of evidence grade 1. On the other hand, there is an anti-metabolic drug, TAS-102. It's acts differently. It's, however, also an orally taken drug. And there is also level of evidence grade 1. The toxicity profiles between these drugs is different.
I think that you are a good candidate for two possible third-line therapies, either regorafenib, which is a targeted therapy called a multikinase inhibitor, more specifically a protein kinase inhibitor, or there's TAS-102, which is a treatment that combines two chemotherapy drugs.
Okay.
Regorafenib works by blocking proteins called protein kinases on cancer cells that encourage the cancer to grow. It also stops the cancer cells from developing blood vessels that they need. So regorafenib is a cancer growth blocker as it aims to stop the cancer growing for a time. It's an oral treatment, so you can typically manage this treatment from home. You take tablets once a day for 3 weeks, and then you stop your treatment for a week, and that's one treatment cycle. Another option is a combined chemotherapy agent known as TAS-102. Now, this is a combination of two treatments that stop cancer cells from dividing. TAS-102 is also oral and is taken within an hour of a meal for 2 sets of 5 days over a 28-day treatment cycle. Does that make sense?
I think so. As I remember, I have had targeted therapy before, but I'm confused. How is regorafenib and targeted therapy different to what I've had before?
Yes, you're right. You've previously had a type of targeted therapy called an EGFR inhibitor. They work in a different way. If you recall, these treatments require intravenous infusions every 14 days. And while EGFR inhibitors can be used in third-line therapy, these are not appropriate for you as you've already received these treatments, so are unlikely to respond as well at this stage.
The key points to consider when you're communicating in this setting are that you have to avoid misleading treatment aims. Explain in lay terms that not every patient will have a benefit of his third-line treatment options, and not every patient is the same. So different drugs work differently in different patients, and you might not predict whether one or the other option is working in an individual patient. When you talk about side effects, you have to tell the patient that not every patient will experience all side effects. However, it's not predictive. When you talk about third-line treatment options, you have to list this option with all the advantages and disadvantages for each drug.
I think that you're a good candidate for either regorafenib, which is a protein kinase inhibitor, or TAS-102, which is a treatment that combines two chemotherapy drugs.
Okay.
Regorafenib blocks protein kinases, so inhibits cancer growth. It also stops the cancer cells from growing blood cells that they need. It's oral treatment, and you can manage this treatment from home. The treatment cycle would involve oral administration once daily for the first 21 days of a 28-day cycle. Another treatment would be TAS-102, which is a combined anti-neoplastic agent. It is also orally administered twice a day within 1 hour of a meal for 2 sets of 5 days over a 28-day treatment cycle. You've previously had a type of targeted therapy that was an antibody against a protein called epidermal growth factor receptor, or EGFR. Antibodies against EGFR work by attaching themselves to proteins called EGFRs, which are on some cancer cells, which stops the proteins from reaching the cancer cells and therefore stops them growing. As you may remember, these treatments require intravenous infusions every 14 days. While antibodies against EGFR can be used in third-line therapy, these are not appropriate for you as you've already received these treatments and aren't likely to have an optimal response at this stage.
So how do I know which is best for me?
Don't worry, I can advise. Both regorafenib and TAS-102 have been shown in clinical studies to extend survival. They have also been recommended by international guidelines, so each is potentially a good option depending on the individual. I realise what I've explained is quite technical. You don't need to remember it, it's just important you realise there are options. The decision we need to make together is which treatment would be best for you, based on treatments you've had before, your current health, and what your treatment goals are. Does that make sense?
I don't know. There's a lot to take in.
I understand, and I can work with you on that. We'll give you some written information to take away. There's little to differentiate the treatments in terms of how well they work, so we have to look at the overall picture, and that includes survival, how we manage your symptoms, deal with potential side effects, and generally maintain your quality of life as best as possible.
Okay. Could you explain again what you think would be best for me? I don't want the treatment that becomes a burden. I've had enough of coming into hospital, and I would want to have my treatment at home.
Okay, I can advise on that. But ultimately, the choice of therapy, if any, is your decision. You are a good candidate for regorafenib because of the previous treatments you've been on. Also, you have responded quite well to treatment so far and seem reasonably well. Regorafenib is an oral tablet that is taken once a day, so you wouldn't have the burden of coming to hospital for treatment, and it's straightforward to manage. So you'd hopefully get the outcomes you want to enable you to make your daughter's graduation. To make the decision, I suggest we reflect again on what you want to achieve with the treatment while maintaining a reasonable quality of life.
Okay. Would it give me more time than the other treatment options?
It isn't really that simple, unfortunately. We can try one treatment and then use the other afterwards if need be. These third-line treatments have shown an overall survival benefit in clinical trials. Some patients experienced a survival benefit of some months. But it is not possible to compare how a specific patient will respond to a particular treatment.
At this stage of the disease, you should avoid to raise unmet expectations from the patient side. So being realistic, what is the treatment aim? In the third-line setting, it's most likely stabilization of the disease, assurance of quality of life, improving prognosis, and not cure or shrinkage of the tumor. By explaining this to your patient, use simple words and avoid too technically complex phrases.
Both regorafenib and TAS-102 have been shown in clinical studies to extend survival. In addition, these treatments have been recommended by ESMO and NCCN guidelines, dependent on individual patient circumstances, so each is potentially a good option depending on the particular patient. There's little to differentiate the treatments from the standpoint of how well they work, so we have to look at the overall picture. That includes survival, how we can manage your symptoms, deal with potential side effects, and generally maintain your quality of life as best as possible.
Oh, okay. It's a little confusing, really, to understand what's best.
I can advise on that. I think we need to start you on regorafenib, as your first-line treatment was the chemotherapy FOLFOX and an antibody against EGFR. And your second-line therapy was bevacizumab.
OK. Would it give me more time than the other treatment options?
It isn't really as simple as that. I mean, ultimately, we can try one treatment and then use the other afterwards if need be.
We are now looking on the most common side effects, how to manage them, and how you can communicate this to your patient.
OK, so what are the risks or side effects of regorafenib? Now, I remember another patient in my support group mentioning side effects from third-line treatment.
Side effects of treatment are very important to consider. However, it is important to remember that you are in control and many of these can be addressed. So, although you are not coming into hospital for treatment, you would have a regular review at the clinic so we can deal with these before they become too much of an issue. The advantage of tablets is that we can interrupt and change the dose, while with IV medication they are given completely and can't be removed. So I'd strongly encourage you to contact us if you are having any trouble managing your treatment or side effects so that we can help manage these. To give you an idea of the most common side effects of regorafenib seen in clinical studies are tiredness, decreased appetite, hand-foot skin reactions, diarrhea, mouth sores, weight loss, infection, high blood pressure and voice changes. I know this may seem like a long list, but it's worth you knowing what is most often reported in trials. These are experienced by at least 30% of people who take it, but the key is early identification and management of these to stop them getting worse. Most can be managed with supportive measures and sometimes medication.
I'm not sure I want to have to deal with all those side effects.
You have to remember that these are potential side effects. Everyone is different and side effects vary from person to person. You might not have all or any of these side effects, or you may develop a side effect we have not discussed. And remember, we can work together to adapt the dose if necessary to address these side effects. Side effects are typically worst during the first treatment cycle, but then improve.
OK.
The most important aspects in the communication perspectives, you should not minimize the significance of side effects. You should explain how side effects might affect the quality of life. Tell your patients how you can manage toxicities of a drug. Make it clear that your patient understands the delivery of the drug, especially when compared to other treatment options.
OK, so what are the risks or side effects of regorafenib? I remember another patient in my support group mentioning side effects from third-line treatment.
Any treatment has risk of side effects. The most common side effects of regorafenib seen in clinical studies are fatigue, decreased appetite, hand-foot skin reactions, diarrhea, mucositis, weight loss, infection, hypertension and dysphonia. These are experienced by at least 30% of people, but we can deal with these by adjusting dose.
I'm not sure I want to have to deal with all those side effects.
Everyone is different and side effects vary from person to person. I still believe the benefits of treatment outweigh the disadvantages.
OK then.
The final step in the communication framework is to emphasize the treatment aim and explain your patient how treatment success might look like.
This is a decision we can make together, and the oncology nurses will also support you with it. Let's think again about what we're trying to achieve. If we can get through 2 cycles of treatment, you are likely to see a benefit. Also, as we've discussed before, remember that lifestyle and diet choices will have an impact on your well-being too. All these factors will give you a good chance of enjoying your daughter's graduation and maintain your quality of life. I can give you some written information to help you understand the potential side effects and how we could deal with them. Do you feel you understand what I've explained just now?
I think so. It's just hard not knowing how it could affect me.
Don't feel under pressure, and I or another member of my team can help you get any further information you need to make your decision. Do you have any further questions, Sandra?
No. I guess I just need to get started, don't I?
If you're comfortable, that makes sense. I'll arrange for us to talk again. Then, if you're ready to move ahead with this treatment, we can take it forward.
Thank you.
The final points of the conversation should include to make sure the patient understands what you have explained. Give your patient the time to ask appropriate questions. Explain timing of the next steps, but don't put pressure on the patient for treatment decisions.
So, I'd recommend we get things moving, so we'll make arrangements to start treatment as soon as we can. Just let one of the team know if you have any questions. I'll also ask them to find you some background reading to take away.
Okay. Thank you.
We have now outlined the 5-step discussion framework in enabling patients to make better decisions for third-line colorectal cancer. And we hope this video helps you in collaborative decision-making with your patients. A more thorough e-learning and educational support will be provided through GI Connect, so be sure to check them out. We really hope that you found this video useful and that you will share it with your colleagues.